Let's get started, okay? Diane, why don't you go first? Ladies first.
Let's see. Are you having difficulty intubating after pre-hospital use of the combo tube? How many of you have your pre-hospital folks use combo tubes are you seeing more and more of that, those of you that have that? One of the things we've noticed is that our paramedics are they do a lot of intubations, but the ones that are using the combo tubes are getting really used to using the combo tubes and are losing their intubation skills, so that's kind of a problem. I'll tell you the thing about the combo tube. All of the product inserts say, you know, deflate the proximal balloon, move it to the left in the mouth, insert the blade, blah, blah, blah. They lie. Take the thing out, okay? Just take it out. It's the size of a 9 endotracheal tube external diameter. That balloon, even if you deflate the pharyngeal balloon, is still huge and in your way. Just if you do that, though, if you take it out, know that you take down the balloons in the same order as you put them up. So just undo 1 and 2. Just don't even think about where they are. Just pull one, take a syringe, stick it in the pilot balloon and suck it dry. Because if you just cut the pilot balloon, the pharyngeal balloon will not deflate. It doesn't have enough sort of elasticity to deflate. You have to suck it dry. The other thing to do is before you pull the tube, stick a suction catheter down the distal tip of the combo tube and suck out the stomach if you can. Have suction handy and just don't even try to intubate around it. Get it out and re-intubate around it. If you think you're going to have trouble intubating, you may want to go ahead and use it for a while until you kind of regroup and figure out what the problem is. But don't try to intubate around it. It's almost impossible.
Let me also say that in the field, sometimes what you can do is nothing. That is, you can bag them. There's a great study on kids, which was done in L.A., and what that study, by the way, no EMT in the country likes that study. But what it said was kids did better if they weren't intubated and they just bagged them on the way in. That's Gaucher's study, right? Yeah, that basically said if you just bagged them on the way in, they actually did better than those kids who were intubated. Now, there was some mild selection bias in that study. But you know what? It's pretty well done. And what it says is maybe sometimes we shouldn't be shoving things down people's throats.
I think especially in the urban setting, it's silliness when you have medics on scene for 20 minutes trying to put an ET tube in around the corner from the hospital.
Right.
All right. Go ahead, you have a comment?
Yeah, they also basically are showing the same kind of thing in the trauma patients now. A whole bunch of studies down in San Diego say they do worse. They do worse if they're intubated in the field, and the Gaucher study said they did worse if they were intubated. It wasn't neutral, so it said, well, we're going to continue to do this because they didn't do any worse, didn't do any better. They did worse when they were intubated, and the trauma patients, and that studies in San Diego have gone over and over and over, and they're large studies looking at the advantage of intubating trauma patients in the field as well. Now, there's always this issue about, well, were they all equally sick or injured kind of thing? And to the best of their ability, the answer is yes.
See, the problem is we've built an empire, and the fire unions and everybody else pays people, they hire people, they promote people, they send them to courses. The truth of the matter is, if we had automatic defibrillators and LMAs, we'd probably have the exact same outcome. He actually took the drug box and threw it out. Because if you actually ask this question, how many people do we save with the drug box in the field, particularly in the urban setting? It's damn near nobody.
Now, I have to be careful. Matt Stadd's a paramedic back there, so
Diane and I actually were talking about this too, and there's a lot of data coming out. In particular, the head injured trauma patients do much worse. And part of the reason there's a lot of evidence coming out now that it's the carbon dioxide level that you drive them down to when you intubate them. And we all know when we intubate somebody, your adrenaline level's a little bit high. As soon as the tube's in, you tend to hyperventilate those people. If you do not have a capnometer attached to it, not that little doorknob that changes colors, which I think is an absolutely useless piece of dirt, but an actual capnometer where you can see the number, what their PCO2 is, you will hyperventilate those people. And hyperventilating trauma patients, we're not talking about down to a PCO2 of 35. We're talking about the kind of anxious, rhythmic bagging that you do very quickly on these people where you blow their CO2 down to 20, probably produces a lot of neurologic damage. And I'll tell you, we've had the quantitative capnometers for well over a decade and a half now. When you put that tube in, the first impulse of whoever is squeezing that bag is to hyperventilate them, and you watch the CO2s plummet, and you really have to say to the tech or whoever is doing it, see that number, I want it to stay at 40 or 35 or somewhere in that range. And I think some of the bad outcomes in the pre-hospital intubations, especially in the head trauma patients, are a result of hyperventilating these people. Oh, deep sedation. Deep sedation versus anesthesia, etomidate, propofol, ketamine. The RN State Board pushed to have the MDs being asked to push the first dose. Yeah, that's actually at our place. If you're doing procedural sedation, the physician has to push the first dose unless you're tied up doing something else. But if you're giving it for an intubation, the nurse can do it. I don't have a big problem with it one way or the other. It's an inconvenience, but you know what? If it makes somebody happy, that's fine. But all the subsequent doses can be pushed by the RN. The other questions are, do they have to be MPO for 4 to 6 hours? The answer is no. There's a number of very good studies out there that show they don't need to be. Do you need an IV if you're giving IM ketamine? We actually give IM ketamine to get an IV in kids. But no, you don't, absolutely don't need it. And that's one of the big advantages of ketamine. I will tell you, we have what's called the ProSed registry. It's procedural sedation in the community hospital emergency department. 10 hospitals in it. We're just putting together the first publications out of it. We presented some data last year at SAEM. It's got about 1,000 cases in it. And a lot of ketamine, a lot of propofol, fair amount of etomidate. And I will tell you that the complication rates by the emergency physicians are markedly less than anything published in the anesthesia literature. Average complication rate across the board is about 4%, but that includes things like became hypoxic, repositioned head, hypoxia went away. There's only, 2.2% were considered major complications, and they were things like you had to bag valve mask the patient. Nobody needed to be intubated, but more importantly, and I think that the real take-home message is, nobody's disposition was changed because of that. In other words, it wasn't that they got hypoxic and the air doc couldn't handle it and then they wound up in the unit and that type of stuff. Everybody had the same disposition, regardless of the complication, and the emergency physicians were able to handle all those transient little bag them for a couple minutes or put them on some additional oxygen. So that when this data comes out, it's going to say very clearly all of these drugs in the hands of emergency physicians are done very, very safely.
Yeah, by the way, I don't think it matters which one you use, whether you're a Versed man or propofol or whatever it is. Get good with something, and the real question is that you use it, and you don't succumb to the nursing thing about, do we have to do one of those things because we got to write up a piece of paper, we got to put them on a pulse ox, we got to do all this stuff. You know what? We can make this a much better experience. And I'll tell you, pain management, if you haven't moved into this era and all these other techniques we've got, you're behind the time. We can make this an almost painless experience. And as I said, I think the other day, a sign of an emergency department that hasn't grown up is if you still own papoose boards.
Yeah.
We don't have them.
Yep. And it's interesting that they're required by the whoever puts out that list of essential equipment in the emergency department.
What about steroid use in mononucleosis and pharyngitis? Well, they use it, and usually use it in fairly bad cases, and they're also getting, in the strep cases, they're getting antibiotics. And I personally have seen a couple where we were kind of concerned about them. It was over the weekend, or they didn't have any doctor, and so we said, listen, come back tomorrow. We want to see how you're doing, kind of thing. And they come back, and they're a lot better. You don't know whether it was the antibiotic, you don't know whether it was the steroids, kind of thing. But it is commonly used, and I think personally that if somebody's really got a nasty sore throat, it's not unreasonable to do. The ENT doctors have been doing it for a long time in secret. They haven't published a lot about this, but it is used. I don't think there's any downside to it.
I got to tell you, we rarely get to follow the people, but there's a number of people who you're not quite sure, is that a peritonsillar abscess or just some excessive edema there. You give them a hit of and we use Decadron. You give them the Decadron, give them your favorite narcotic, a couple of milligrams of Dilaudid, run some fluid in them, put them in the corner, and come back and check them in 6 hours, and these people are dramatically better. And I think it's probably just that they get a rush from the Decadron, but it still makes, but I still think they do get better with it, yeah.
How much Decadron?
I give them 10.
You give them what's in the bottle. You know, it's like, it's,
By the way, I don't think there's a study comparing Solumedrol and Decadron or anything. I don't care which one you use. If you gave them 125 of Solumedrol, you'd probably have just about the same effect. The point is, if it is an edema, swelling, inflammation process, and those things help to back that off, again, I'm in agreement with the fact that if it looks nasty and they're uncomfortable, I'm happy to go ahead and give it. Doesn't
Yeah,
bother
I
me a
did.
bit.
My nephew was like, dying from this horrible sore throat. He couldn't eat. He was wasting away. My sister brought him in, who's the world's greatest hypochondriac, and she was convinced that he had, pharyngeal carcinoma or something. And we gave him a hit of Decadron and sent him back home. And she called me like 6 hours later, going, "It's a miracle."
No, it's Decadron.
Yeah.
yeah, there are very, very few studies about dose ranging for steroids and just about anything. The most recent ones are the ones that talked about the septic shock and said, okay, well, let's give 100 or 200 of Solu-Cortef kind of thing. But when they talk about asthma or this condition, they just pick a number.
Next, inpatient or outpatient treatment of pneumothorax. First thing you got to decide is, what are you treating? If it's simple air, and occasionally we get a young man in who's been doing something. He's not sure exactly what, but there's a needle mark, and now there's a lung that's down. And that's because there's nothing on their arms anyway. So now he's got a little pneumothorax there. We take the small catheters, stick them in, hook them up to the valve, the flutter valve, tape that to their chest, and we'll bring them back in and recheck them the next day.
I thought you were supposed to hook them up the wall suction.
No.
Wasn't that?
No
No.
reason. There's no reason to ever put anybody on wall suction for a simple non-traumatic pneumothorax.
Just take them and tape. Isn't that what you guys are doing? Taping that to the chest and bring them back the next day and recheck them?
We aspirate.
Yeah.
Yep.
Yeah, that's all we do.
I mean, it will come up, if you put them on the water seal, no matter what you do, it comes up on its own. You don't have to hook them up. And these people with the spontaneous pneumothoraxes that have been there for 24 hours or longer, you put them up to up to suction and inflate that thing real quick, they go into unilateral pulmonary edema.
Exactly.
Just hook them up to either the Heimlich valve, a water seal, whatever you want, walk away, it'll drift up on its own.
Yeah, there was a time when we would actually open one of those expensive Plurivacs for all these things.
Yeah.
And by God, those things are expensive. I mean, we didn't have the old, I remember the days of the old glass bottles, but the plastic unit, as soon as you open that thing up, you got a couple $100 into this thing, and they don't need it.
Yeah, to put the tubes and stuff, we have those Cook wire guided ones. Anybody using them? Those things are spectacular. It's just like putting a CVP in. But if you don't have them, what you can do is take your regular CVP set that you would normally use. It's got the triple lumen type thing. Put the dilator in, dilate, just go over the rib, put the wire in, put the dilator over it, and then take a regular pediatric 8 French chest tube. It fits right over the dilator, and it'll slide, or I'm sorry, it fits right over the guide wire. It'll slide over the space made by that dilator and goes into the chest wall just fine. So you don't have to make any bigger incision than about this big in anybody you're putting a chest tube in for just air.
I don't know how to answer this one. Plan B postcoital prophylaxis. Any strategy when nurses are morally opposed to giving it? I'll toss that out to you guys.
Your nurses can't impose their morality on a patient-by-patient basis for something like that. And if they are, there has to be at any one point in the emergency department someone who's not morally opposed to it.
Yep. I think that's right. I mean, what I don't want to do is take somebody and seriously challenge a belief. And a lot of people who feel that way have serious beliefs that way. But then there ought to be somebody else who can handle that situation. We're not the only ones involved in this. The pharmacists have a terrible problem with this. And I think that we just need to make sure that the patient doesn't pay the price for somebody else's moral conviction. And I don't mind if you don't do it, but there ought to be somebody who can do it. We actually had a doc who was a Word of God Catholic who would not do that. But we always made sure he had scripts with somebody else's name on it. Yeah. Literally, that was the solution. Yeah, I signed a bunch of scripts and handed to him. What? Probably. Yeah. But he was there that he could pass them out.
Well, it's also...
State medical board, we find somebody running scripts, leaving them for the
Well, there is also a similar kind of thing when you write a script for somebody who has a venereal disease and you want to give their partners more than 10 scripts, how many partners they have kind of thing. Medication, because it's been shown that they're more likely to take it if you do that. But you're writing a script for somebody who you've not seen as a patient. They've not come to the office. They haven't done any of those things.
There's a lot of countries that are in favor of that, and that's what they do. I'm willing to do that. I'd be very happy to give them other scripts for their contacts if we also get a concomitant state law which relieves us of liability. See, the question is, what is the greater good? Treating contacts or having a potential allergic reaction to the stuff? If I knew that I was free from the state, from liability on the issue, I'm happy to treat their contacts by giving out a script. But this debate's going on all over the place. I'm just not going to hand out 5 scripts to people that I don't know anything about, that nobody medically has spoken to. That how do you know what they're allergic to?
Well, also, in some states, Plan B is given by the pharmacists. If you go there, they're free to...
No script.
And I used to know the number, but it's not a lot of states where Plan B is given by the pharmacist without a script from a doctor.
Yeah.
I think it's a relatively small number.
We've had the same problem with certain physicians who don't want to give it, and basically, we had one who we wrote a standing order so that it gets dispensed from the department with a standing order. Somebody has to write a prescription.
Yeah.
That's interesting, too, because we have one of those sexual assault response team kind of things at our hospital. We're the regional place for that, and my name is on the bottom of every one of those Plan Bs, prophylactic this, prophylactic. I never even see these people, but there's a standing order protocol kind of thing adopted by the medical staff that says we can do that because they're there really for evidence collection. They're not there for a medical kind of checkup kind of thing.
But even the Catholic hospitals, and I work at a Catholic hospital, and so you have said if you do the pregnancy test and it is negative, you are permitted to give post-exposure prophylaxis.
Yeah, Catholic Healthcare West, which is 42 hospitals, the biggest nonprofit in the West, they've taken that position too.
I used to work at Syncope in Phoenix, and we signed a form when we started our employment about 2 years ago that says that you will not write any birth control prescription.
Well,
That's the difference between birth control.
Well, but the idea being that it encompasses. I won't say that necessarily affects my clinical practice,
But no, I'm in Catholic Health East, on the other end of the continent, and they sent a specific memo to all the physicians that said, yes, you are allowed to give post-exposure, hormonal therapy for patients, provided they have a negative pregnancy test.
Yeah, we were never asked to sign anything like that. Although maybe these hospitals, some of them are clearly more Catholic than others. Well, I mean, I'm serious because our hospital is a community hospital that was bought by this organization and has no religious affiliation.
and we have Plan B in Texas, and so if you want to write it, you just.
So maybe they're over and above the minimums.
Yeah, as long as the nuns aren't coming down asking for the Plan B, you're okay.
That's why it's in the pictures.
Yeah.
That's right. What's that number again?
Yeah. God bless you.
Sister Maria, you got the next one?
What is the best drug for agitated patients? Every study that's looked at, it still says droperidol outperforms
Haldol.
any of the others.
Yeah.
Well, no, now the newer drugs. What's the new one that's out there?
Zyprexa.
Geodon. All the head-to-head studies show that it outperforms it, and it's still one of the safest drugs out there. So,
Yeah, my only problem with the droperidol is the problem the government gave us. It's
Yeah.
not with the drug, it's with
Right.
the government. And since it's got a black box warning now, a lot of my guys are afraid to use that drug.
how many had it taken out of their emergency department? Yeah, it's ludicrous. I mean,
Well, look at all these people over here who haven't. Or you just not want to answer. You mean because the hospitals believe that they're assuming a liability now that they don't want the doctors to even involve them potentially. So, because every time the doctor gets sued, the hospital gets sued too. So they basically said we're not into this. Thank you very much. So they pulled it at our hospital.
We've used it, we probably use 4 or 5 doses a day. It's usually 5 milligrams, so it's a whopping dose IV in the mostly agitated, intoxicated patients. And we do put them on a monitor. We've never seen any arrhythmia, and we're beginning to think that there's a cardioprotective effect from the concomitant use of alcohol and cocaine when you give them the droperidol. Because we've never had any of those arrhythmias that they talk about.
Well, the fact is that we're going to talk about unusual side effects of antibiotics, and then we're talking about cardiac arrhythmias and erythromites and that kind of stuff. Well, it's also been shown to be even worse with psychotropic drugs. The Mellaril is at the top of the list in terms of sudden death. You know, so cardiac patients have been getting Mellaril. Well, it's not very common now, but in the past, that was at the top of the list. Haldol's on that list. Droperidol was on that list. Chlorpromazine is on that list. They're all QT prolongers. They've all been associated with increased risk of sudden death. And how this one little drug got picked out and said, well, we're going to take you out of the list now is very strange, because this literature is not it's been around a long time.
In answer to your question, if I'm in a hospital where I can still use droperidol, I use that. Otherwise, most of our places, the cheapest drug they buy, they buy in bulk, is still Haldol, and I don't have any problem with using Haldol.
And again, the other thing is you can give Haldol IV. A lot of people are afraid to give it IV. It can be given IV.
We can give it all the time.
Yeah.
Should Demerol be taken out of the ER? There's two on that. This is about this Demerol-free hospital kind of crap. I don't think it should be taken out of the emergency department. I do think that maybe it should not be used repetitively in an inpatient setting, particularly in older people, particularly in those who have renal compromise. And it's actually pretty interesting. Our hospital had 7 seizures related to what they believe to be Demerol over a period of time, but nobody ever really put the numbers together to say, hey, this seems to be a problem, until they brought this out. So the idea of using it repetitively in the hospital is one thing, but in the ER, we're not using it repetitively. And there are people who say, this is what works best for my whatever, and you get yourself into a little pissing match when you say, well, I'm sorry, we're going to have to give you this instead of that, when we're talking about one dose of this drug. So I think that it's kind of like not one size fits all.
We went through that phase, and actually what's happening is even our fairly chronic pain patients now understand that Demerol is going the way of the buffalo, and they've gotten pretty happy with Dilaudid. I tend to be a very conservative guy. I'm still, if morphine works, we buy it for 10 cents a shot. If you actually look at if you take out what they call the bonding that goes with this, all the things you got to pay because you got to have bonded carriers and the way you have to do it, there's nothing cheaper than morphine. And so I tend to use it. Do we have some Demerol around? Yes, we do, but it's interesting. We're getting less and less requests for Demerol from the patients. And I think there's a change in the country as to what the drug seekers are interested in.
Yeah, I don't have any problem with it. I just don't like the idea of it saying, you cannot do this, ever. We're pulling it out, it's not here, and I think that that's kind of overkill.
There's a question that goes along with that. Please comment on the use of the PCA pumps in the ED for managing moderate to severe pain. We rarely, if ever, do that, because if the pain is that severe and we're admitting the patient, hopefully they get out of there. And generally, in my place, we're able to get them out in a reasonable time frame. I'd have no problem with it if they had to be down there for 24 hours or something, but I just don't have that much experience with it.
I think the literature on the PCA pumps is, the problem is you always have to get like the anesthesia team or somebody to get it set up for you. But from a nursing perspective and from a physician perspective, it does free you up very quickly in terms of you have a sickler or somebody like that. They just get put on this thing. There's a protocol for it, and now they're down there 5-6 hours. You're not constantly being asked, they need some more pain medicine, those kind of things. They kind of run on autopilot. So from a nursing physician time perspective, it's worthwhile, but otherwise, I agree with Greg.
Although I do think we have a paper that I recall that said basically if that stuff was started in the emergency department for people who were going to be admitted to the hospital, that it would be more effective to do that than to get this gaposis where they're going to the floor, now it's going to take more time, they're not getting their pain medicine because the doctor's not there anymore because now they're on the floor.
I think that's individual depending on how your hospital, who has to set it up, the team, all those sorts of things. But I will say this, Anybody who's looked at this study about treating sicklers, if you hit them hard early on, they control it. Invariably, they use less medication and they're out of the hospital faster than if you start playing games with the, there's always some nurse who wants to say, well, I'll give them 5 milligrams of morphine, but I'm certainly not going to give them 8 or 10. You know what? Once you've decided to give the medicine, give enough and snow them early on, and then the way their endorphins work, they'll drop quicker and they'll be out of the hospital faster.
I think are you next?
I just did that one.
Any specific recommendations on blood culture draws that is decrease the use of them? First of all, we have to get rid of the CMS completely since they're now obligating us to get them for pneumonia. That is a huge problem, I think, that it fortunately is being addressed. But the other thing is know when you get yield from blood cultures and when you don't. For instance, young healthy woman with pyelo, don't get a blood culture. All you're going to get is a phone call the next day from the lab saying, oh my God, they're growing gram-negative rods 4 out of 4 bottles, and the patient looks fabulous. We know that. We know that they get bacteremic 18 to 25%
We're going to have to call
of the
that,
time.
they're growing out
That's the next-
gram-positive
that's the next-
cocci.
That's the
right,
next
the
lecture,
contaminant.
by the way.
Yeah. So
That's
this
the
is-
next
so-
lecture.
Oh, is it?
Yes.
Blood culture lecture?
Blood culture lecture.
There you go.
yes.
You'll learn all about it
Yeah.
next lecture.
Here, should you repair a wound unnecessarily if the patient is likely to be more satisfied despite the higher cost?
That's a good
Well,
question.
you and I live in a political world, and it's always easy. I always find it interesting when I'm on the panel with certain people. I mean, Jerry Hoffman is a good example, that he wants to take a very pure approach to the science. And those of us who work in a community hospital where our contract is in trouble, we actually have to take a political view of what this is. You know what? I'd work it out with the patient. If they think they need a couple of stitches, it's okay by me. I don't view you as less of a doctor if you've gone along with the patient's request on this.
Although one of the things I think is very helpful in a case like that is to volunteer what you would do if it was a member of your family.
Yes.
You take them into your special confidence when you do that and say, listen, if you were a member of my family, here's what I would do. Because they're under the delusion that you would actually take care of their family well.
That's right. If it was my wife or somebody I loved, this is what I would do. Right, exactly.
But the other thing is that those little ditzel wounds that you just need the one stitch in, a lot of times now they can just glue the things closed. So we had one of the pediatricians brought her kid in with this. I mean, it's tiny little thing on the scalp, and you never sew the thing up, but it's gaping open just a little. And I went through the whole spiel with her, and then I looked at her face, and it was just like, you're not going to be happy unless I put a staple in this arch. She goes, no, I'm not. It's like, take the stapler, hold still, Twinkie, click. Okay, you happy now? I'm happy now.
I always remember we had a plastic surgeon at our place. Mother came in with this small girl, maybe 7 years old. She had a cut so small that I had to put my lenses on to see it. And what does mother want? Plastic surgery. Well, in our situation, that's what we get. So I'd seen the plastic surgeon going through. He was in his greens doing some stuff. I call him up, and of course he's devastatingly handsome. He's got this beautiful voice, and I say, Paul, you want to come down and do this one? He says, yes. Does mother understand I send a separate bill? I said, yes, we've had that discussion. So he comes down 20 minutes later in a $4,000 Armani suit. He's got a $400 Bulgari tie on, and he wants one of the nurses to scrub with him. So they gown him, put gloves on, he's got a mask on, he puts in 2 6-0 nylons, and of course has the nurse cut. And at the end he goes, there. And of course mother's mesmerized, and he removes his glove like he was removing his condom. And he's talking and this and the thing, they've left. I said, Paul? He said, yes, Greg. I said, and he just looked at me and he said, mother paid for the magic show. And then he looks at his nails and says, and she got it. He said, when you send a bill for $600 for 2 6-0 nylon sutures, they got to get something for their money.
But actually, you bring up a good point. It is the show more than the...
Well, particularly for a plastic surgeon. He sells a psychosexual product, and he has to... I'm sorry. I'm sorry.
It's true.
You wouldn't... You wouldn't go to a plastic surgeon who looked like a toad, okay? You don't care if your urologist looks like a toad, but you wouldn't go to a plastic surgeon. You should see this guy's wife. He built his own wife. And of course, they're like a Barbie and Ken set that you buy, but that's their own advertising for what they do.
Here's our access to plastic surgery. They bring a guy in from the jail who's had his ear bitten off. The ear is gone, okay? The guy bit it off, spit it in the toilet, and flushed it. So now this guy comes in with no ear. I call up plastics who says, you know, we have one plastic surgeon who's on call for the entire hospital all the time, and we only call him when we really, really, really need him. So I call him and say, John, listen, this is bad. He said, okay, here's what you're going to do, Al. He goes, because I'm not coming in because we have to reconstruct this, everything else. He goes, create a bunch of advancement flaps around where the ear was, pull the tissue over, just make sure you don't oversew the canal itself. And then, you know, just tell him to, you know, wear a monocle instead of glasses, and I'll see him in, you know, follow-up. That's what we did. Created the advancement flaps, pulled the thing over, and sent him back to the jail.
Our plastic surgeons are our own interns. They're rotating on the plastic
Yeah.
surgery service. We get transfers for plastic surgery repair from other hospitals to our hospital, and I call and it's our intern who comes downstairs and sews them. It's just
Those guys are so, some of these, the first years, you know, who come down, they're the plastic surgeon. They're so damn young, we have to pin their rubber gloves to their sleeves. I mean, it's unbelievable. And we've closed a lot more wounds than they have.
But you know what? The only reason you call him is you don't have the time to do it.
That's right.
Here.
Yeah.
You know, spend an hour here. Work of a pediatric syncope. Diane did that lecture, which is outstanding on the syncope in the adults. Pediatric syncope is number one, history. You really want to get the history of what exactly happened to them. You know, if it's, and you can pick up vasovagal pretty easily. Standing in line at the cafeteria and just got woozy and went to ground. The ones you worry about is syncope associated with activity. The kid was actually doing something. They're out playing, playing sports, running around, and went to ground. Those are the ones you need to be a lot more careful about. In the emergency department, it's EKG, looking for prolonged QT syndrome, any of those kind of things, WPW, evidence of that type of stuff. It's not a bad idea to stick them on a monitor for a little bit. Usually get a chest x-ray, see what the heart size looks like, listen to them if you hear a murmur. Most kids who've got something bad, congenital, it's going to be picked up before a year of age. What you're going to miss is the conduction abnormalities, which can show up at a later date.
And just understand, in the department, you're not going to pick up most of those, and that's why if that history is funky, then they need to have an event monitor of some kind, Holter or something, because laying there on that cot in your department, the yield is so small. Just be honest with them. Yeah, we're going to do your EKG, but we're probably going to have to see what it looks like over 3 or 4 days. And by the way, if they don't have a spell while they're wearing the monitor isn't negative, it's indeterminate.
Right.
And then they got to wear it till they have a spell.
Yeah, because they're 12 years old or 8 years old, and this is the first event they had. It's a little bit difficult. A lot of these kids will have one event and won't have another one for 2 years. But the only other thing you have to do is you have to close the loop somewhere. Either put them in, they're going to follow up with their pediatrician. You talk to one of the cardiologists. They're going to follow up with the cardiologist. Somewhere along the line, the loop gets closed. You're not going to make the diagnosis in the emergency department unless they do something funky there.
Yeah, the other thing is, what makes you think it's cardiac? I think the big differential there is that when there's a transient loss of consciousness, it's cardiac or it's neuro. Right. And you can be having an absence spell, you can be having other things, which for all the world, they say, well, I was just sort of out.
Right.
And then two minutes later, I'm fine. That doesn't have to be cardiac. That can certainly be neurologic.
Yep.
How many of you do any kind of sports physicals? I guess the family doctors. Usually sports physicals where do you have a hernia? But we really don't care about that because it's really about, do you have idiopathic hypertrophic subaortic stenosis, which is going to have you drop dead on the basketball court like a number of people do, or these football players or whatever it is. And yet it has been looked at, and the yield of doing those, everybody's echoing everybody's heart to see if you have a big septum, is infinitesimally small, so that it's not considered to be worthwhile to do that. But that's really the thing that we're looking for. So the idea of it came during exercise or exertion, is certainly a red flag.
It's interesting. There was a huge controversy 6 months ago where they were one of the pro teams or one of the college teams was requiring all the athletes to have an echocardiogram, and the echoes picked up some stuff, and then there was all kinds of problems with you ruined their career. This guy was going to make $1 million. Now he can't make it. You've branded them as being inferior and those kind of things. And it was it was actually on ESPN, had the debates going back and forth, and they had cardiologists and team owners and players and everything else. And it was fascinating that these players were adamant that they shouldn't get this test done because if it found something, it would ruin their career. Never mind the fact that if they didn't find something, they were going to drop dead. That didn't matter to them.
Case in point, this season, and I'm from Detroit, near Detroit, which is hockey town. That's what we do, hockey. Everybody's crazy about hockey. There are no empty seats at the Joe. On the bench, a guy had just finished his shift, goes to the bench and drops dead. I mean, he's in cardiac arrest. They brought the paddles over, popped him, and brought him back.
Yeah, it's
and then
dramatic.
He's waving to the crowd as they're moving him out. Now the real story begins. Well, now he's home. You know, they've taken him to Ford or one of those places. The cardiologists have seen him. They don't know what to do. He's now pissed as hell because he wants to get back on the ice. And they don't know what to do about this. So now they start this gradual thing at the rink. He's wearing a halter. As he gets faster and faster around the rink, is his conduction system going to change? And he was going to bring action against the Red Wings if they didn't let him back on the ice, because this was his life. And he was willing to sign a waiver that said, if I drop dead, I hold you harmless.
Yeah, it's scary. The other subgroup is the athletes who drop dead and they do the post on them and they have a cocaine heart. That's a whole different thing. But the irony of that is, was it in California? There was a real high-profile case where the guy dropped dead on the court, and if I remember correctly, they had the defibrillator, but nobody knew how to use it, and so they wheeled the guy off, and the guy didn't get the defibrillator. Anyway, long story short, they did the post on him, and his minister and everybody in the neighborhood was up in arms. They were going to sue the arena and the team and everything else. And then it came out that this guy had a cocaine heart. And they said, the ME office said, we want to release this because we think there will be a benefit from it that tell kids you're not indestructible, that you are at risk if you do drugs. We think there will be a greater good if this gets out. And the rest of I forget who it was, the minister, whoever said, no, we've got to suppress this. Don't let anybody know that he died because he was abusing drugs. That would actually destroy his image. And there was a big argument that went back and forth. Yes, it would tarnish his image, but it would in the overall scheme of things, it would be a much greater good for the community in general. And I think it was suppressed. I don't think it ever got out.
Except here, you heard it first.
Yeah.
What do we got? Who's next?
But you got something?
Well, this is a good question, actually. This is a person that has an angulated fracture, like of the wrist, and the orthopedist says splint it, and they'll see him in the next day and reduce it then. And the family is upset because you got a right angle kind of wrist now. The splint now is going like in a, like this. And but the neurovascular is intact. He said, what do you think we ought to do in a case like that? What do you think we ought to do? Should we just try to reduce it, numb it up with a local block or something like that, because it is so, or just lean on the orthopedist?
Yeah. Stop.
I would lean on the orthopedist.
I grew up in the era of the local block, the hematoma block, and you know what? What that was an excuse for get 3 more people and hold the kid down because they don't work.
But even in
Hematoma blocks don't work.
I mean, if it's a kid, it's easy enough to get hit with ketamine. The adults are a little bit tougher ones. We use a lot of beer blocks, which I think work great. Not what your version.
I'll tell you, we've gone away from the beer block, and simply because of a couple of little problems we had, and we don't mind using Brevitol or something like that for those people. They do just fine.
Yeah.
But the more fundamental question is why doesn't the orthopedic come in and do his job?
In our scenario, we just went one from the PAs coming in at night to the orthopedic surgeons covering at night. So now we can't get them reduced at night.
are we taking on too much liability by doing it at night? Like, let's say there was a bad outcome. Is it me? And now, you know.
It depends on what you write down. I pleaded, begged, and tried to bribe the orthopedist. They would not come in. I felt, okay, I would do my best to preserve this patient's function. There's that argument. There's the argument of just bed them down in your department with a splint and have ortho stop by on their way to the hospital in the morning. I think the timing of it makes a difference too. If it's 2 in the morning, I have no problem with bedding the patient down, giving them some analgesics, and having, pack them in ice, and ortho can see them, first thing in the morning.
When the PAs come on.
Exactly.
We actually have a really good relationship with our orthopedic surgeons. This is a problem. We reduce probably 90% of the risk fractures that we see that are significantly displaced. Propofol, C-arm,
Right.
conscious sedation.
Are you adults or kids?
Huh?
Adults or kids? Both.
Unless it's, if it's a complicated fracture that looks like it involves
Right.
growth, like whatever.
If it's all the way off and you got to get the thing back up and on, that's one thing. But if it's just angulated, you're just kind of cracking it back.
No, we take them all the way back.
Right.
When they're completely off and put them back on. And the rule of thumb is that we give it a single try, and if we can't get it, then the orthopedist comes in and they never come in.
Right, but that's
But is that, are we putting?
no, that's well within your. When we did this course in Williamsburg, there was a bunch of guys who said, "What are you guys talking about? We always, take care of the wrist fractures. We put them in a sugar tongue and send them to see ortho when PRN."
By the way, you have 2 problems here. One of them is a science question. That is, does it make any difference whether you put it back in now or in 8 hours or 10 hours or 12 hours? The answer to that is probably not. And I watch this go on all the time in England. These guys weren't going to come in and do that at that moment in time. They were going to see them the next day. In fact, that was true with appendices in England. They weren't going to operate on them that night. They'll take them out the next day. And then you have the political problem of what to tell the family and the parents and all that other sort of thing. And that's the more difficult issue. And that's why I like the idea of, it's 1, 2, 3 o'clock in the morning, just bedding them down, say, we're going to let them relax. We're going to take care of the pain.
We're going to let the swelling go down.
We're going to let the swelling go down, and then the orthopod will come in. But I know, I certainly have orthopods who this goes across the spectrum. Some of them want to take care of them that night, and some of them will stop there first thing at 7 o'clock in the morning and do it.
But you are absolutely well within your purview of emergency physicians reducing distal radius. We do them under beer blocks more than anything. Yeah. It depends on how comfortable you are doing it. Now, we do have access to, our orthopods are pretty responsive, so if it's a reasonable hour, we give them the call first. If they say, I can't come in, would you do it? No problem. But it's interesting that you describe what has evolved over decades in emergency medicine, which is, we'll give it 1 or 2 good tries, and then if we can't, we'll call the specialist in any areas. Whereas you go back 2 decades, you didn't even give it that 1 or 2 tries. It was, oh my God, you have to come in and see this. I have a dislocated hip. You must come in and do it. Now they don't come in unless we can't get it back in.
Yeah, but there are certain joints, by the way, where we're much more experienced than the orthopods. I've done 500 shoulders. About 500. That's a lot of shoulders. We have lots of techniques. They're no better at doing that than I am, putting those things back in. There are other areas of the body, however, where, I just don't do it that much, and the liability is high enough that I would just soon have them be involved in it. But now all these replacement hips that pop out.
Yeah.
We put those things back in. In fact, if I didn't put those things back in and was calling them in for that, I would kind of be in trouble because they expect us to do that sort of stuff.
It is very interesting where if you work at a site where there's a big disparity between what some docs will do and others won't. Like we have docs who are very, very comfortable doing complex facial lacerations, but we have one doc who just is terrified of suturing faces. So, this individual is constantly calling plastics or ENT or somebody else to come in and do facial lacerations that nobody else would bat an eye at. And what you wind up with is those guys then come back to the group and say, you got to fix this. We can't be called in for just those types of things. And what it comes down to is your entire group really has to practice as one individual now. You can't have that, waxing and waning. It's like, depending on who's on, this is what we do type of thing.
There's been a huge shift, though. I remember when emergency medicine was, back before there was a board, I was doing this. And there really was sort of a witch doctor mentality. Patient came in and you told him which doctor was going to see him next. And now what happens is we've actually become more expert at certain things than those specialists. I mean, clearly, I can do conscious sedation much better than the orthopods. And in fact, the orthopod's coming in, he always says, Greg, you're going to be there to put him to sleep, aren't you? Yeah, of course. I'm sitting there, so I'll take that end of the patient, he'll take the other. But believe me, our stock has risen tremendously because we take care of these things.
Anyway, okay, here you go. Is ultrasound-guided central line placement going to become the standard of care? Well, it isn't the standard of care right now, because if you look at how it's done, it isn't done. So by de facto, it is not the standard of care. However, in the IV talk, there are 4 papers that say it is better, safer, more effective. You name it, it's better when it's done under ultrasound. And so when it's not a commando procedure, the radiologists are getting asked more and more to do this because of their ability to visualize, et cetera, et cetera.
But I think the emergency physicians are getting more adept at it too. The biggest problem is getting access to the devices. I mean, if you can get the ultrasound, you basically teach yourself how to do it.
By the way, in training emergency docs, residents to do ultrasound, and I think that the ultrasound machine is the stethoscope of this century. This is where they need to be. But they need to be very specific. There are only 4 or 5 things we need to do with that instrument, but you need to be good with those 4 or 5 things. I don't want you looking for half-centimeter lesions in the liver, looking for metastases and stuff like that. But there are 4 or 5 things. These need to be checked off the box. This is what we're going to train you for, and they need to do a lot of it. Because when they leave the training program and go out to a community hospital, they got to show, and there's always some radiologist on that committee, that they have adequate experience to meet that need.
But I will tell you, the training in ultrasound is very, very, very sketchy in emergency medicine residency. Some people come out very adept at it, and some people come out very shaky on it.
Remember the story I told you yesterday about my daughter marrying into the radiology family at Duke? Well, it's very interesting that Susan Promise is now the residency director there. And she and I went out to dinner with Carl Raven, of course, my daughter's father-in-law. And the next day, he went ahead and told his radiologist, you will train the emergency medicine residents in ultrasound. And here are the 5 procedures they have to know how to do. So sometimes these marriages of convenience work out okay.
When attempting to admit a patient to the chest pain observation unit, will often get resistance from the cardiologist if they have had a recent negative stress test or negative cath. What is the shelf life of each of these tests?
Good question.
Very good question.
Well, the shelf life of a stress test is it's not very good because it's only 85% accurate to begin with. So you only have a sensitivity of about 85% on, regardless of whether you do it with nucleotides, whether you do it with echo or whatnot. So if they do the stress test and it's negative and they have not many other risk factors, you probably send them home. They come back with recurrent chest pain and they had a negative stress test, it's time for a Kathlyn, those guys.
And
And by the way, the 64 slice machine, it's a fantastic technology in search of a disease process, yet we don't know how to use it. And no matter whatever your cardiologist tells you, we don't have all the data yet as to how the 64 slice CT is going to play into who comes in, who goes out, what we're going to put on them. It's not ready for prime time. And we need more papers on this subject. I don't know, what you guys seeing anything different or not?
Well, I've seen some spectacular pictures from, our hospital got one of those things, and certainly for cerebral vascular anatomy, it's absolutely amazing. You can pick up aneurysms very, very well, very easily with it. But the brain doesn't beat that much. What I think what we're learning with it, and we are in the middle of a learning curve, is radiologists need a consultant to do it, because what you have to do is slow the heart down, and they are very, very timid about that. So they give them a little bit of this, a little bit of Inderal, a little bit of low pressure, a little bit more low pressure. When you really need somebody who's a little bit more gutsy to just bring the heart rate down to 50 and let it, and get the study done, and then let it drift back up on its own. So.
And I don't know anybody who would comment about a negative angiogram. I mean, there is those vasospastic, people who get chest pain,
smalls, yeah.
who have normal coronary arteries, but it is pretty compelling if they've had a really clean cath. So
Right.
is it 1 year, 6 months?
But I have to be careful, though. What they say is that a lot of the heart attacks are not caused by that 75-80% stenosis. It's that 40% stenosis that didn't need stenting, right, that ulcerated.
Yeah.
So if you're right, if you get something that says your coronaries are clear, I think they give it a 5-year warranty on that one. But if you got somebody who, they had like a couple scattered lesions and 40% type of thing, they didn't need anything done, that person you need to take seriously.
Okay, any more?
There's one here on asthma intubation. When do you, how do you, interesting, intubating an asthmatic is a big deal. It's not anything to be taken lightly. That being said, if you talk to an emergency doc who tells you they haven't intubated an asthmatic in the last 5 years, they're not seeing enough sick asthmatics. The reality is, asthma is a terrible disease. There are patients that will die of asthma. It's usually, by the way, sudden severe asthmatics, not the I've been sick for 4 or 5 days. It's the I got really tight 20 minutes ago. That's the person that's going to die. When to intubate, you have to use your clinical judgment. Clearly respiratory failure, if they're going down the tubes. And by the way, the asthmatic that goes down the tubes doesn't get sleepy like the COPDer does. They get agitated. They will rip off their mask. They will not cooperate. That's because they have incredible air hunger. They're in catechol storm. They're profoundly a diaphoretic, combative asthmatic needs to be intubated. You treat them if you need to, hit them hard if you can, do what you have to, but there are certain people that will have to be intubated, and it's just the reality of it. We don't do a lot, but when you need it, you need it. And if you do it, the controversy that comes up, especially for those of us that have practiced for a while, is how? I'm really good at nasotracheal intubations. I like to intubate already he's still breathing, I don't want to take away his breathing asthmatic, I'm just going to do it through the nose. The problem with that is to do a nasotracheal intubation, you need a relatively cooperative patient. And God forbid you get a bloody mess if you get a nasal trauma from that. So really the best thing to do is probably controlled rapid sequence intubation. And with the caveat of which drugs you're going to pick and which you aren't. Okay, Sux is fine, by the way, this whole theoretic acetylcholine issue. Yeah. It's not real. Get whatever induction agent you're comfortable with. And if you want to choose ketamine on purpose, this is a good time to do it. Okay, it does cause bronchodilation, and be prepared for everything to go wrong. Remember that intubating an asthmatic doesn't cure the problem. Okay, all it does is now makes you fight the lungs directly.
Yeah, just remember where the problem is. We're not dealing with an upper airway question. See, everybody always gets the tube in and then says, well, God, we get that wonderful feeling like we're in control. You're not in control. All you are is you've got about a 6-inch more direct pipe to be banging, but the problem is down here. It's at the bronchioles. It's not in the big tubes. So you haven't won anything yet. All you've done is if they tire out, and this is why they have to be intubated, because now they're tired. And just the physical act of moving the air is getting so hard for them. But anybody who thinks that because you got a tube in, it isn't still a disaster and you aren't in big trouble, you've missed the situation. They need continuous.
Be prepared for the lung to drop.
Yeah, they need continuous albuterol.
Yeah.
What about before you're to the point where you want to intubate using MAG or Heliox?
There's actually an extraordinarily good set of guidelines out there to sort of the approach. The National Heart, Lung, and Blood Institute updates them about every 2 years. And they, God bless them, finally said, well, okay, the data's not fabulous, but go ahead and consider using MAG in the severe asthmatic in the acute setting. So MAG is fine. Heliox, the thing about Heliox is the only data that shows that it really does much. It's actually been incredibly disappointing data in asthma, is that it's really only the acidotic asthmatic that is hypoxic and acidotic that has any benefit from Heliox. And non-invasive ventilation has also been extraordinarily disappointing in dealing with the asthmatic, which kind of, if you think about it, makes sense. That non-invasive ventilation wouldn't be particularly useful.
You understand the Heliox is a nice theory about laminar flow and the amount of resistance of the gas, but that isn't really the problem that's going on here. And so I think that data is, you certainly aren't below the standard of care not using Heliox in your department.
But
that's not there yet.
Yeah, there is that theory, though, that Heliox does work on some people. We just aren't sure which ones it's going to work on. So there's absolutely zero problem with giving it a whack. In bad bronchiolitics, the little kids, clearly and the bad ones, it does make a difference. I think you look at most of the asthma Heliox studies that don't show any difference, is they pick too broad of a category. They're not the ones that Diane's talking about, that really sick, air-hungry, agitated patient. They're like Louis who's wheezing a little bit.
Well, there's no reason not to do it. And you really would like to avoid intubating these people if you at all can, so you basically throw the kitchen sink at them if you have the time. If you don't have the time, well, that's another story.
Yeah, I use it all the time. Absolutely.
You mean IV epi?
Or
How are you
sub-Q.
giving it?
I've given it every which way. I mean, sub-Q is usually the quickest.
The evolution of epinephrine and asthma, if you want to kind of sort of, because those of us that are practicing a long time used to use it all the time. We use
Yeah.
sub-Q epi all the time.
Listen, that's how we grew up. We gave epi, and then on the way out the door, we gave them susprin.
Susprin on the way, the long-acting stuff. The evolution of that was what we had at first, and then there was terbutaline. You could be a little more, ooh, I'm cool and hot and specific. But then when they compared it to inhaled agents were just as good, and so epi kind of fell by the wayside. What never got done that should have been done is a really good study looking at the severe asthmatic,
Right.
and it does epi really make a difference in that group. I will tell you, there's one area of problem. There is one study out there that in the U.S. literature anyway, that looks at IV epinephrine for bad asthmatics. It was a study from UCLA. They took a huge time span, 20 plus years, of a total of less than 50 cases, and just pulled the charts, looked at them, said they gave IV epi, there was no specific dose given, and they basically said everybody did okay, so it must be fine. That is not a study.
No.
That proves nothing. And what happened after that is some people that in our community said, oh, cool, let's use IV epi. Be very careful using IV epinephrine.
I think personally that is a great strategy. If you have somebody who comes in who's super tight, to give them 0.3 of epi sub-Q like they used to do in the 70s while you're gathering all the inhalational stuff, because that will give them, I believe, a jump start. But because once you start inhaling that adrenergic, it's not much medicine. The technique has to be good. It's 2.5 milligrams. It's going to take a while to get that down there. So I think that it's not unreasonable, although I have no data to prove that it's reasonable in those cases to give them a little jump start.
By the way, what the data will show now, the public health data, is that we've become very good with mild asthma. We're much better with moderate asthma. And yet the actual number of death from asthma is slightly up, particularly in urban settings. And nobody knows exactly what the reason is, but no matter how good we are, there's going to be a certain group of people who die. And of course, nobody likes to hear that, including your malpractice carrier, by the way.
Including the asthmatics.
Including the asthmatics. But there's a group there that, with all your best intents, anybody ever had an asthmatic die? I mean, it's a very frightening experience because you think you should be able to save them. You know, I've had them die.
It's one of the other things too is that this passive hypercapnia, where in fact you're not trying to ventilate them but down to a PCO2 of 40 anymore. You're just trying to oxygenate these people. You don't care where that PCO2 goes.
Exactly.
It's basically not to generate a lot of pressure. Low pressure, frequent oxygenation is the goal, not CO2.
Yeah.
40 years ago, we were taught that epinephrine did not work very well in the acidotic patient. So therefore, we gave epinephrine. We also gave bicarbonate to
Yeah.
get them up.
Yeah,
Where did that go?
that went the way of the buffalo.
Well, you know, because 30 years ago when we were started doing this stuff, we didn't know about any of that bicarb stuff, but we used to make adrenergic gorillas out of these people by giving them 0.3 of epi every 20 minutes in the attempt to break this asthma spell, and you would turn them into an adrenergic dynamo because you'd given them this epinephrine,
You gave them a mop and turned them
epinephrine.
loose on the ER.
Yeah, right.
And we would, and that was this. They were so loaded with this stuff because the fact is it didn't go away in 20 minutes. So we were just adding one dose on top of another on top of another, and then we would give them a boost of susprin out the door kind of thing. It's a wonder that we got away with it as much as we did. Yep. But during that period, there was no bicarb given, and that was kind of standard therapy, or your aminophylline drip. It's amazing we didn't kill more people than we did.
Yeah.
The gentleman's name was Matenko, and he published in the New England Journal in '73 the Matenko formula for giving aminophylline. And all of us learned that religiously. And believe me, when we finally realized that we didn't need to do this anymore, it was painful for all of us.
I remember when the first article came out in the Annals, I had just finished residency, and it came out that compared, it was a randomized controlled study with asthmatics who got IV aminophylline and didn't get anything. And I read, just the abstract. I said, this is bullshit. There's no way, because I had this regimen down. When you were an asthmatic, you hit the door, you got epi, your aminophylline drip was started. I had this whole little thing down. It was very hard to give that up. I mean, I was wedded to that.
5.6 milligrams per kilogram.
Yeah.
Yeah, see, the funny thing is, you are a prisoner of when you trained and with whom you trained.
I could use those neurons for something else right now if I could get it out of my head.
The biggest mistake made with the young asthmatics particularly is they're not on a decent steroid program, inhaled steroid program, which they use religiously. That's where we're going to win this war. It's not in somebody who's about to die in the department right now, because we don't have a lot of new tricks there. I think it's consistent use of the steroid as an outpatient, and a lot of family practice people and pediatricians have not been rigid enough about making them use the stuff.
Yeah, you'd have to ask, why would you not send any asthmatic who was sick enough to come to you in the first place out on some kind of steroids? It's like, and yet when you look at studies, a surprisingly small subset of people still leave the ERs without getting any kind of steroids.
I see people that come in that are PRN or
Right. No, the rescue inhaler, the beta adrenergic, that's fine. But the steroid ought to be on a consistent basis, then they'll be okay. I got another one here.
Okay.
How often do you request patient consent prior to ordering urine drug screens? Again, it's why you're doing it. If they've come in from at work, I mean, they get a drug screen whether they want it or not. If they've come in from various things, mostly I don't talk to the patient about it. After all, I don't really get their permission to draw their blood. That was on the main sheet that they signed, and so I rarely talk about it before we send the stuff off. I mean, I just don't do it.
Well, I think there's another point of view, though. It doesn't matter really whether they're on any drugs if they've had a car accident kind of thing. In terms of the medical aspects of a car accident and trauma, the literature says it doesn't matter whether you're drunk or not. Your outcomes will be the same. As in fact, you may be better off if you're drunk in terms of your outcomes. So that to say I'm doing this for a medical reason to ascertain why you have a depressed level of consciousness, well, you better get the CAT scan and not depend on the fact that the alcohol level is 200 anyway in a trauma case. So the fact of the matter is, when you do a blood alcohol, and in most trauma cases, it's not for the medicine. So the question is, what is it for?
But I don't think it's unreasonable to get an alcohol level in someone with a depressed level of consciousness. But
Well, it can only screw you up because
as long as you manage them independent of that.
Yeah, and as long as what you're doing is to find out if you have another problem. But I agree with Rick. You never ascribe a decreasing mental status to a blood alcohol level unless you're actually serving drinks in your department, because they should be improving, not getting worse. And the streets are littered with emergency docs who said, well, he's drunk.
Yeah.
We'll check him again in 6 hours. Yeah.
All right.
You ready?
There's a question.
What do you do when family member brings mother in because she's a little bit sick, not a whole lot, but they're leaving the town? And they want to
The Friday afternoon suitcase sign.
Oh, this is the positive suitcase sign.
Positive suitcase sign.
Yes. We're well aware of the positive suitcase sign. Then you know that you have a political problem right up front. And what I try and do is always put myself on their side and say, I'll see what I can do. Unfortunately, they don't let me do certain things anymore. It's the great they. Well, who's the great they? Those are the same people who fly the black helicopters. And those are the people that we're all answerable to, is they. So I just say, they don't let me, but let me see what I can do for you. So I'm acting as the patient's advocate here. But I know, right off the bat that there ain't going to be a bed for that patient.
In Los Angeles, you can hear the wheels squeaking in the parking lot as they're on their way to Las Vegas for the weekend as they dropped off Granny kind of thing,
You know what, I honestly think that for these people who are taking somebody at home, that is a community service, that they're at least keeping their family member. We should have a place, an old Howard Johnson's, it's been converted, which is a dump and run old lady place, where you can drop by, leave your mom for the weekend, go have a good time, come back and pick up your mom. All right.
Okay. Rick, pick it.